Thank you. The next speaker is Dr. Shebin Salim, microbial keratitis and thyroid eye disease.
Thyroid eye disease is complex autoimmune inflammatory condition. Sight-threatening TED could be either due to dysthyroid optic neuropathy or exposure keratopathy related complications. So the tear film itself is unstable in thyroid eye disease. This along with the lack of thalamus and exposure keratopathy further predisposes for microbial keratitis. So this is a retrospective case series of 3 patients. Clinical features, microbiological profile and management outcomes were studied. The microbial keratitis was diagnosed based on clinical features alone or with a microbiological confirmation. So this was our first case, 50-year-old gentleman who presented with the right eye swelling, decrease in vision of 7 weeks duration. He was elsewhere diagnosed as a case of active thyroid eye disease and has already received 2.5 gram IVMP before presenting to us. He had multiple systemic comorbidities, and on examination his visual acuity was counting finger 2 meter in the right eye and 618 in the left eye. There was lid edema, lack of thalamus, extraocular movement restriction, severe chemosis, conjunctival congestion, carangular inflammation. This along with the spontaneous and gaze-evoked orbital pain, the clinical activity score was coming 6 out of 7. So this was his right eye cornea. There was severe exposure keratopathy with a focal anterior stromal infiltrate and hypopyon. So he had both eyes non-proliferative diabetic retinopathy, imaging by MRI scan of the orbit showing bilateral enlarged extraocular muscles which is more on the right side with apical crowding. So the challenges here, on one side we have active thyroid eye disease and the other side possible infectious keratitis with the multiple systemic comorbidities. The first priority was managing the infectious keratitis. The corneal scraping was done which did not reveal any organism. He was started on empirical treatment. For the ocular surface protection, we did an right upper blepharotomy with lower lid retractor release, lateral canthotomy, cantholysis and tarsorrhaphy. For controlling the orbital inflammation, he received 1 dose of injection dexamethasone followed by low dose oral steroids and later systemic immunosuppression once the corneal ulcer started healing. So why we have to do such an aggressive ocular surface protection? Because if you do tarsorrhaphy alone, this in turn increases the intraorbital pressure and compresses the optic nerve if the apex is already crowded. That was the case here. So we have to do the additional relaxing procedures. Also, the tarsorrhaphy alone will not be effective in covering the ocular surface in this kind of severe thyroid eye disease, and it can give away because of ongoing orbital inflammation. So this was a 2 weeks follow-up. At 1 month follow-up, this is the last follow-up 14 months. We can see that visual acuity in the right eye improved into 6/12. This was the second case, 66-year-old lady with bilateral severe thyroid eye disease, sight-threatening thyroid eye disease. And here we can see that the clinical activity score was 7 out of 7. So this is both eyes cornea. Here there was severe exposure keratopathy on both sides with a focal infiltrate on the right eye. Again, the fundus right eye had no view, left eye had disc hemorrhages and edema suggestive of compressive optic neuropathy. The imaging confirmed the same. So again, this case also was managed in a similar way. Here the initial scraping showed fungal hyphae in the KOH and the culture revealed Aspergillus species. So patient was started on topical and oral antifungals. The ocular surface managed as before, and since she had compressive optic neuropathy, we gave 1 more dose of IVMP, but following which the intravenous steroids were deferred because of the active infection and switched into low dose oral steroids and later as the systemic immunosuppressant once the corneal ulcer started healing. She also underwent optic canal and orbital decompression because of the compressive optic neuropathy. At 6 weeks, the ulcer was healed and the edema reduced, and she also underwent orbital radiation once the ulcer is completely healed. This is at 6 months follow-up. She had cataract, underwent cataract surgery, following which she started pursuing diplopia and hence underwent squint surgery also. Final follow-up at 3 years, right eye visual acuity improved to 6.9, left eye 6.6. The third case, 54-year-old lady who had an active TED in the left eye with a clinical activity score of 6 out of 7, and she had severe exposure keratopathy in the left eye and a stromal infiltrate. Here we can see that, and hypopyon. So for her, this is the CT imaging showing bilateral enlarged extraocular muscles with apical crowding. So in this case, again, the initial corneal scraping was negative. She was started on empirical treatment. The ocular surface was protected. So, for the orbital inflammation, following 1 dose of injection dexamethasone, she was started on low dose steroids and immunosuppressants later. She was improving, but unfortunately, at 3 weeks follow-up, she had an increase in the corneal infiltrate with thinning and hypopyoid, and increase in the medial exposure again. So repeat scraping was done, which showed aspergillus, started on antifungals. The medial blepharotomy and tarsorrhaphy was repeated. Also underwent blepharotomy and lateral tarsorrhaphy in the right eye also because of exposure. So following which, once the ulcer healed, she underwent orbital decompression and radiation. At 7 months, visual acuity in the left eye improved to 624. So microbial keratitis in thyroid eye disease is very rare, less reported. Only one large series is there of 13 patients. So here we can see that while all 3 patients in our series presented the focal corneal infiltrate, in the previous series it was advanced keratitis with more than 75% of patients. And there the organisms were mainly bacterial, while we had aspergillus species in 2 out of 3 patients. In their study, evisceration was done in 4 patients, penetrating keratoplasty in one. And we did an aggressive ocular surface protection. TED was managed tailored to each patient. To conclude, antimicrobial treatment, ocular surface protection, and controlling the disease activity all are equally important for a optimal outcome. Thank you.
Yes, sir. Sir, Bastian, sir. So all the 3 had microorganisms in the second time, huh? First one and the
2 patients, sir.
first one we don't know.
No, sir.
So not sure whether it's microbial, but clinically it looked like
Clinically, it looked-
all the 3 cases look like acute exophthalmos.
Yes, sir.
All are acute exophthalmos, and not surprised cornea is getting involved. Once they come late, it will be an involved cornea. Absolutely. So I would have been happier if you had put the thyroid levels, and you just mentioned low TSH in one case, but you should put the thyroid levels. That will also determine what you should do to control the thyroid. You have managed all that too with the compressive optic neuropathy. Getting 6 is 6 9, huh?
6 in one eye and 6 9 in the
yeah,
other eye.
that is you have treated well, but the thyroid parameters are equally important in this. And then you have to control whether it's hypo. It could be hyper, could be hypo, or anything. No, so including
It was
yeah,
controlled.
you make a mention of that.
Yes, yes.
That is equally important.
Okay. Thank you, sir.
Thank you, ma.